Hi, good afternoon, everyone. It's the time of the week once again, and we all know what that means, right? It's time for another interesting ITV episode. So it is my privilege to welcome you all to episode 6 of TMC ITV. I am Dr. Nilo Flor Cruz, and I have with me today Dr. Manilito Itok Reyes. Join us this afternoon for another virtual learning opportunity.
Thank you, Nilo. Good afternoon to all of our viewers. We have prepared an interesting program for all of you, especially now that we are celebrating Sight Saving Month. Welcome to our sixth episode entitled My Daily Drops Maximizing Glaucoma Medications.
The glaucoma section of the Medical City Eye and Vision Institute invited experts in our field to discuss the common issues, questions, and queries when it comes to the medical management of this condition.
To begin our program, let us hear from the country manager of Mundi Pharma, our sponsor for this episode. To give his opening remarks is Sir Boyet Arellano, the Business Operation Director of Mundi Pharma.
A pleasant evening, doctors. First of all, I would like to thank all of you for being with us here tonight. We hope that tonight's session can provide you with more insight and information that you will find useful as you uphold your duties as doctors of vision. As we all know, the current COVID-19 pandemic continues to affect our lives. And for all of you as ophthalmologists, I can only imagine all the challenges and the pressure that most of you might be experiencing right now when it comes to handling and taking care of your patients. Now that we're in a phase we call new normal, your services now becomes more crucial for those who are in need of your expertise. Apart from toggling between surgeries and consultation, another duty that you need to constantly do as a healthcare professional is to make sure that you're always updated about the latest medical advancement in your specific field. And at this time, it is important that you have a portal or a channel that will enable you to gather information and discover new learning in an easy, accessible, and safe way. And that portal is one of the highlights tonight. This evening, we will show you our way of promoting innovative and accessible learning for doctors, including those who are infotech beginners, new to access of training in their fingertips. Visit iShine online today and learn more. Good evening.
Thank you, Mr. Arellano, for that warm welcome for our viewers. And thank you to Mundi Pharma for teaming up with us to offer our viewers a segment that would be relevant to the times. Our sponsor this afternoon, Mundi Pharma Philippines, will be giving out samples of povidone iodine, betadine, oral gargle, so please stay tuned. Let's not wait any longer as I turn you over to my co-host Itok to introduce our first speaker.
All right, Nilo, let's get this started. One of the things we want to eliminate or minimize in our procedures, especially in this time of pandemic, is infection. Do you agree, Nilo?
Definitely, Itok. And of course, one name that has been synonymous to our pre-op preparations or disinfection, especially in the field of ophthalmology, is betadine. But really, how has betadine Betadine's role changed in the past years and decades, or has it changed at all?
Yeah. Our first speaker, who has been very willing to grace this episode to talk about betadine's protective capabilities, is from a specialization that is close to us ophthalmologists. Dr. Teresa Luisa Cruz, or Tech among his friends, is a graduate of the University of the Philippines College of Medicine. She finished her residency training in otorhinolaryngology, head and neck surgery at the Philippine General Hospital, and subsequently her otology fellowship at the University of Minnesota. Finally, Dr. Cruz also completed her Master of Health Professions Education from the National Training Center for Health Professions of University of Manila. Her current affiliations include Asian Hospital and Medical Center, Medical Center Manila, and UPPGH.
Now, if you have questions, do not hesitate to type down in our chat box, and we will try our best to accommodate all questions during the Q&A later on. Without further ado, let us now give the floor to Dr. Tessa Tech Cruz.
Good day, everyone. Thank you to the Eye and Vision Institute of the Medical City and Bundi Pharma for having me here on EyeTV. This afternoon, I'd like to share with you this module entitled PVPI or PPE, wherein PPE stands for Potential Protection in Epidemics. These are our disclosures. Let's start with some definition of terms. Pandemic refers to an epidemic that has spread over several countries or continents, usually affecting a large number of people. Epidemic refers to an unexpected increase, often sudden, in the number of cases of a disease in a population. Endemic refers to the constant presence and or usual prevalence of a disease or infectious agent in a population within a geographic area. And an outbreak carries the same definition of epidemic, but it is often used for a more limited geographic area. We are now in a pandemic, as we all know. The numbers of COVID-19 patients continue to increase in so many countries around the world and in our very own beloved Philippines, such that we are saddened with this account that we can become the new epicenter of Southeast Asia. But the world is not a stranger to pandemics, epidemics, and outbreaks. It has seen several actually. The coronaviruses are notorious for causing these significant epidemics. The SARS in 2003 and the MERS-CoV outbreak in 2012. We also have the Ebola virus outbreak and the various influenza outbreaks. Now, these pandemics are caused by an infection. And for an infection to perpetuate, there is a chain that has to be maintained, and in the middle of it all is the patient. Of course, it starts with the infectious agent. In the case of COVID-19, we all know it's a virus. It enters the susceptible hosts and then exits the host, and then the mode of transmission facilitates its entry into another potential host, where there may be a reservoir where the virus continues to replicate. So, since we don't have a specific treatment or even a vaccine until now, what we have to do is means of prevention, which is breaking the chain in this area and in this area. So, povidone iodine is one of the agents that is being proposed to be an agent to break this chain of transmission. So what does the preclinical data say about the possible role of povidone iodine in pandemics, epidemics, and outbreaks caused by viruses? So virucidal activities of povidone iodine and other antiseptics were studied in vitro, and as you can see across the board, PVPI solution has good killing rate for adenovirus, herpes, rubella, measles, mumps, flu, rotavirus, polio, rhinovirus, the common cold virus, and even HIV. So, for many of the viruses that cause the diseases that we are familiar with, it works very well in vitro. And not only that, it also works for exotic disease viruses. Contrary to chlorine and quaternary ammonium compound, iodine, even in low concentration, is very effective in vitro for all these viruses tested. So, what is the activity of povidone iodine against coronaviruses, the family to which SARS-CoV-2 virus belongs? So, the virucidal activity was tested against many viruses, both enveloped and non-enveloped, including the dreaded coronaviruses. And they found that iodophores are effective to inactivate coronaviruses. All PVPI products inactivated SARS-CoV-1 virus within 2 minutes of exposure. And therefore, in 2015, it was also proven that it was virucidal against the modified vaccinia virus Ankara. It is effective in vitro against the MERS coronavirus and the SARS coronavirus, which I think are cousins, if not brothers or sisters, of the SARS-CoV-2 virus. So hand and skin hygiene is very important for us nowadays. We have been told to do frequent hand washing, singing to the tune of Happy Birthday. So hand washing with iodine as one key protective factor against SARS infection was found. Hand antisepsis by the healthcare workers with iodine was associated with less SARS infection. This is for SARS-CoV-1. And povidone iodine is more effective than plain soap for hand decontamination. Povidone iodine scrub and alcohol hand rub are superior to plain soap hand wash for subsequent decontamination. And some reputable institutions, and we are very familiar with those in our own setting and abroad, already have included povidone iodine as part of their armamentarium for skin and surface disinfectants in the fight against COVID-19. But again, what's important to us is povidone iodine use in the respiratory tract. Because after all, we are concerned with COVID-19, which is mainly a respiratory disease. So, what is its track record? For the common cold and influenza, it was shown that gargling with PVPI was useful in the prevention of these diseases. For an influenza epidemic, it was shown that gargling with PVPI 4 to 5 times a day in a school will limit the spread of the virus from infected to non-infected pupils. For upper respiratory tract infections and influenza-like illnesses, gargling with PVPI made the incidence of the illness lower as compared to those who gargled with water and those in the control group. For chronic respiratory diseases prone to acute exacerbations, PVPI gargling provided a significant reduction in the incidence of acute exacerbations. And of course, as was already mentioned, PVPI has proven killing rate in vitro against a number of viruses, including those that are notorious for causing epidemics. So the most important question for us today is, what about PVPI use in COVID-19? The WHO says infectious disease outbreaks are periods of great uncertainty. Events unfold, resources and capacities that are often limited are stretched yet further, and decisions for a public health response must be made quickly, even though the evidence for decision making may be scant. Therefore, in literature now, in scientific media, we find quite a number of proposals proposing the use of povidone iodine not only in the throat and mouth, but also in the nose as a PPE for COVID-19. And these proposals share common basis. The basis for these proposals are the pandemic status of COVID-19, that it's potentially fatal, that it's transmitted and it's highly infectious, mainly airborne and aerosol, and therefore prevention of transmission is truly essential. To continue, we all know of the high risk and incidence of healthcare workers being infected, the paucity of other available PPE for us, the higher viral load in the nasopharynx, the nose, the mouth, and the throat, the high percentage of asymptomatic and mild COVID positive patients, and PVPI was the agent recommended in these proposals because of its historic and proven in vitro virucidal activity against coronaviruses, and of course, its safety profile through the decades. Let me go through those items one by one, the items in the last slide. First is the high risk of healthcare worker infections. In China, more than 3,300 healthcare workers were infected, 4% at one point. In Spain, as high as 13.6% in March of their COVID positives were healthcare workers. And in the UK, they reported about 30% of all cases are related to healthcare workers. And in our very own setting, the DOH at one point reported 20% of all COVID positive patients to be healthcare workers. So what does it do to our healthcare system? It's really a burden. If this continues, more staff absences will be incurred and there may be depletion of workforces who will take care of our patients. When these health workers go home, they can spread the infection to the family members and to the community. And in the hospital, the healthcare workers can spread COVID-19 to non-COVID-19 patients admitted in the hospitals for other reasons. And on a more personal note, we all know the fear, the anxiety, and the true sadness we have as healthcare workers every time we hear of a colleague or a friend infected with COVID-19. And even one friend succumbing to COVID-19 is much too many. To continue, another basis is the shortage of available PPEs. We have all been hoarding, buying all these respirators and masks only to find out they may not even fit as well. And again, the high viral load in the nose and the throat. That's why the proposals propose the application not only in the throat as we usually have done through the years, but also in the nose because they found out COVID-19 virus is so high in the nose. The high percentage of asymptomatic patients make us fear that we are dealing with the patients who are really positive when they present with no symptoms. And of course, PVPI is the common agent mentioned in these proposals because being genetically similar to outbreak coronaviruses, the SARS-CoV-2 will be susceptible likely to povidone oral care products just like SARS-CoV-1. Now, when this module was formulated by me, the proposals I saw were still before the time that we had any proof that COVID-19 would be virucidal against SARS-CoV-2. And the good news came July 8, 2020. This article stating that povidone iodine demonstrates rapid in vitro virucidal activity against SARS-CoV-2, the virus causing COVID-19 disease. And you can see from this slide, across the board, ang saya, di ba? There's a 99.99% kill rate. It gives me hope. There's an agent that we can apply in the human body that, although in vitro, shows that it definitely inactivates or kills the COVID-19 virus, whether it's a throat spray, a gargle mouthwash, a skin cleanser, or a skin disinfectant solution. And the last basis for these proposals is the safety profile of PVPI. Iodine absorption is not expected to be problematic, and mucociliary activity of the nasal epithelium is not expected to be adversely affected. No expected effects on the nose's mucosal appearance, mucociliary clearance, sense of smell, subjective perception of nasal airflow in diluted form. So on with the proposals that we find in scientific media. First is this. This is the hallmark from which all the other proposals, I think, were based. The use of povidone iodine nasal spray and mouthwash during the current COVID-19 pandemic may reduce cross-infection and protect healthcare workers. This proposal has a protocolized intranasal and oral application of PVPI both for patients and for healthcare workers to reduce the viral load in the two key areas I keep on mentioning. It is proposed to be used routinely during the care of COVID-19 patients and for all patients, no matter what their COVID-19 status is, who will undergo procedures involving the aerodigestive tract. It is proposed to be used in the hospital setting at 0.5% PVPI solution. Exceptions are those with history of allergy to PVPI, all forms of thyroid disease, current radioactive iodine treatment, lithium therapy, pregnancy, renal failure, and dermatitis herpetiformis. So for those who only have 10% PVPI, as in the authors of this proposal, 1:20 dilution is proposed using sterile water yielding the 0.5% solution. How do you apply? 0.28 to zero point 0.3 ml per nostril if using an atomizer, 2 sprays per nostril. For the remainder of the solution, it is proposed to be used for conscious patients as a gargle and for unconscious patients in the ICU as an oral care sponge. The timing of delivery is every 6 hours in the 24 hours. But for healthcare workers, for example, a nurse with a typical shift in the ICU from 2 p.m. to 10 p.m., that 8-hour shift, they propose every 2 to 3 hours use, maximum of 4 times during that 8-hour sustained contact with COVID-19 patients. Gargle PVPI is well tolerated. The total iodine exposure proposed is well within previously recorded safe limits in those without contraindications for its use. Allergy is extremely rare, and as I said, there is no adverse effects to the nose expected. The second proposal is nasal irrigation and oral oropharyngeal wash are also proposed. It is noteworthy that this advocates nasal irrigation rather than atomized sprays for the theoretical lesser risk of aerosolizing viral particles. The formulations and approach are similar to the first proposal I presented. Now, this institutional consensus proposal from the Department of Otorhinolaryngology of the University of Pennsylvania detailed leaving the nasal and oral PVPI for at least 1 minute prior to starting procedures in the head and neck. Prior to intubation, the Utah Society of Anesthesiology also proposes the application of 0.3 ml of 0.5% PVPI to the nose and the remainder as a gargle, pretty much the same as the first proposal. From the Anesthesia and Analgesia Journal, it is proposed that for known patients and or patients with risk of exposure, use 2 doses of nasal povidone iodine within 1 hour of incision. From the emergency medicine specialist, it is proposed that 15 seconds of gargling many times a day could be useful in preventing COVID-19 transmission in the first phase of the illness and possibly also reduce the body spreading of the virus. The UK British Dental Journal also published the use of PVPI nasal spray and oropharyngeal wash in all patients before any dental examination or procedure. A group of maxillofacial oral surgeons also recommend the coating of the oral cavity and nasal passages of both the patient and the operating room team before any procedure. The American Association of Endodontists also came out with a recommendation for a pre-procedural rinse with 0.2% PVPI. And lastly, in this module, a letter to the editor, SARS-CoV-2 being vulnerable to oxidation from our dental colleagues, also advocating the use of PVPI gargle. So as I said, since I finished this module, I already see some others in the scientific media, but not only there, even in popular media, you will find accounts actually advocating the same thing, the use of PVPI in the nose and throat as a means to decrease transmission of COVID-19. So you see this various, and even on Viber, this was making the rounds. Because of the worthiness of the proposals, please be assured that ongoing clinical trials to demonstrate the benefit of the intranasal and gargling use of PVPI in COVID-19 patients are ongoing in several reputable institutions. So what about PVPI use in the eyes during COVID-19? I came upon this article entitled Comment on Possible Prophylactic PPE Role During Accidental Ocular Exposure to COVID-19. It is a powerful disinfectant with broad-spectrum antimicrobial effect, after all, and is routinely used, as my Ziz bestie, the beautiful Dr. Alnet Tan, told me, in ophthalmology for preoperative preparation of the ocular surface and the adnexa. SARS-CoV-2, however, is primarily a respiratory system virus with aerodigestive spread. The presence of virus in the ocular secretions and its ability to enter the systemic circulation through accidental hand-eye contact are largely unknown, and it may even be doubtful. Further evaluation is even required to determine the actual effect of PVPI on the COVID-19 virus, its presence in the ocular surface. PVPI solutions in humans and repeated dosings as low as 0.6% PVPI gel could be oculotoxic. Therefore, a separate treatment regime needs to be developed to prevent conjunctivitis. Maybe some of you can come up with that. So the usage of PVPI for PPE after accidental ocular exposure to the SARS-CoV-2 remains doubtful at this point. In summary, public health and hospital-acquired infections, epidemics, pandemics, and outbreaks present a significant and fearsome burden both for patients, their families, for public health, and to us, the healthcare workers. Nowadays, it can cause severe illness and even death, especially in people at risk. It is now one of the leading causes of death and morbidity. Sadly, there are still a few specific treatments available, and prevention is still the best armamentarium or weapon that we have to limit the spread of this infection. We do isolation, we do lockdown, we wear our mask, our respirators, we take our vitamins, and let's not forget, hand washing is one of the best preventive measures against the spread of infection, and decreasing transmission by protecting patients and healthcare workers is of paramount importance. PVPI may be considered, depending on your convictions. Iodine has been recognized as an effective antiseptic since the 1800s, and when povidone iodine came, since over 50 years ago, the safety of iodine was even more secured. It's classified as safe and effective with no reported clinical significant resistance, with a broad spectrum antimicrobial efficacy, most especially against the SARS-CoV-2 virus in vitro. As an adjunct to currently recommended PPE use during the management of COVID-19 patients, the use of PVPI in healthcare workers and their patients is being proposed to optimize safety and to minimize the risk of spread of the disease. The proposals presented admittedly extrapolate in vitro findings into the in vivo setting, and confirmed assumptions are made which, under normal circumstances, have to be evidence-based prior to making recommendations. However, given the global urgent need, the applicability of the proposals, the sound basis that I discussed with you, and safety aspects of the proposals, the availability of PVPI and its relatively minimal cost, the disinfection of the hands and oronasal cavities with povidone iodine is being proposed and considered by quite a number of scientists, clinicians, institutions, and organizations, and even actually used already by health professionals and centers at this time of an unprecedented and evolving pandemic such as the COVID-19. Please allow me special shout out to my dear of the friends who take care of myself and my family, Dr. Mamayos Yan, Eric Domingo, my kumare Robitan, my kumpare Eric Domingo, Arnold Salud, Richco, Dino Fontanilla, May Singson, Ma'am Marie Valbuena, I hope you're listening, and former UP Manila Chancellor, Dr. Manuel Agulto. Thank you very much for your kind attention.
Thank you for that informative lecture, Dr. Tech. Truly, studies have shown the protective potential that a drop of povidone iodine can give a surgeon and the patient. We hope this talk was an eye opener, literally and figuratively.
Yes, to give you a clearer insight, we will be addressing some of the questions you have sent through the comments section of our YouTube, of which I'm sure Dr. Ted Cruz is very much ready to answer. All right, our first question, Ted. What is the optimal concentration of the betadine eye drops preoperatively?
So initially, my answer here is I don't know, but you know what? About 2, 3 days ago, again, my Z's bestie, Dr. Alnetan, was so excited and concerned about my webinar. She gave me some leakages. In the Viber, she told me prior to LASIK surgery, 0.25% of PVPI is used 10 minutes prior. And for phaco, is that for cataract surgery, 5% of PVPI 3 to 5 minutes prior to the procedure is used. So that's from Dr. Alnet Tan. Thank you, Alnet.
Yes, I also do that. No, I always tell my resident to put a drop of betadine before you start your procedure, and infections can go away. Thank you, Alnet. Thank you, Ted.
Okay, for the second question, have there been studies on the effectiveness of an oral betadine gargle prior to a procedure or surgery? And how long after the procedure should this be done?
Okay, very, very good question. Um, I'd like to say, I think I've said it about 3, 4 times. The studies I presented are in vitro studies. There is a lack of clinical studies, and that's why I assured you that there are clinical studies going on at this time. Actually, we don't even know the exact dose or concentration in when there is saliva, when there is phlegm, when there is mucus. But there are already many models that have been studied, and they found out that as low as 0.23% of betadine is virucidal for SARS-CoV-1. And so in the proposals, because the PVPI will still be diluted by phlegm, by saliva, they doubled the 0.23 minimum virucidal percentage to zero point 0.5. But they still did not use the 1%. 1% has been tested to be effective without causing much alteration in the normal microbial flora. Because so to the question, are there studies and how many minutes do we apply it beforehand? There is no study. So the ones presented are proposals. They did mathematical computations. But for viruses, for bacteria, there is a clinical study. They have more studies for bacteria. For the oral, they found out that if you give your oral PVPI for patients who are on ventilators, they work against bacteria for 3 hours. They did mathematical computations taking into consideration the clearance time of the nose and throat and these other mathematical computations. And they say in the proposal of Kirk Bailey that there seems to be a 20-minute window wherein PVPI can exert its effects on SARS-CoV-2. So if you will be dealing, if I will do my nasal endoscopy or my laryngoscopy, which is very aerosol generating, I have sort of some 20-minute window if the patient has gargled immediately before the procedure. Now, I'm not saying we should be feeling complacent because some argue that we don't need to do this because we might just feel complacent. We just feel that I think that the proposals feel that there is much to be gained and little to be risked by using this without removing all the other PPEs and protective precautions and practices that we have been studying and we have been proposing. I hope I answered the question.
Yes. Oh,
Okay,
here,
so
there's another question.
there's another question. Okay, attached. Does Multipharma make PPI eye drop? Is there such a
Sir,
formula
ang
for
alam ko po,
eye drop? Mm.
Sir, ang alam ko po, wala po ang Mundi
Yeah.
Pharma, pero alam ko po ang Betadine din po ang pangalan at ito po nga yung 0.5, sorry, ito po yung 5%,
Mhm.
I think, sa drugs.com. I think it's Alcon. The name is Betadine, but to the question, does Mundi Pharma make? I don't think Mundi Pharma has eye drops.
Well, that's something that Mundi Parma has to check.
Thank you.
Okay. Thank you very much to everyone who sent in
I
their
think
questions.
po, Abby is saying,
Go ahead.
Yes, Tech?
Okay.
You want to say something? Okay, go ahead, Tito.
yes,
Sige,
no more.
Okay.
Thank you.
Thank you.
So thank you very much to everyone who sent in their questions to Dr. Cruz. We hope that all your questions were answered and you were able to learn something from her informative and comprehensive lecture. But before we move on to our next segment of this afternoon's episode, let us watch this short clip prepared for us by our sponsor, Mundi Pharma. Okay, that's very nice. So before we proceed to the next segment, we would like to inform everyone that we will be posting a link in our comment section later in the show. This is just for local ophthalmologists. Sorry for our international viewers. Kindly fill out the form completely. The first 150 ophthalmologists who fill out the form completely will be receiving samples of povidone iodine or betadine oral gargle that will be delivered to your respective clinics by our sponsors.
Now, ladies and gentlemen, since the 1980s, the Philippines has always earmarked the month of August as a time to celebrate and commemorate Sight Saving Month. This puts into context our episode today, which serves as TMC Eye and Vision Institute's small contribution to this effort.
That's right, Nilo. So, glaucoma has long been the platform for innovation both in medical development in ophthalmology. Newer drugs bring in new questions regarding the compliance issue, the efficacy, effectivity, the cost, and all the different factors that interact in achieving the ultimate goal of preserving patients' vision and also their quality of life.
Our next speaker for this segment will talk about the meat of this episode, and we are very glad that she agreed to do this episode with us. The next talk will be given by Dr. Maria Imelda Yap Veloso, a glaucoma specialist who trained at Harvard Medical School in Boston. Prior to that, she completed her medical school and ophthalmology residency at the University of the Philippines College of Medicine. At present, she is the vice chair and head of training committee of the Department of Ophthalmology and chief of the Glaucoma Service, Rizal Medical Center.
We hope that her talk on optimizing medical management will enlighten both glaucoma as well as non-glaucoma specialists. After Dr. Velosa's lecture, we will have another esteemed glaucoma specialist who will share with us some of his interesting cases in his practice.
To do the discussion of cases, we have with us one of our colleagues in the glaucoma section of the Medical City.
Dr. Rainier Cobar is a graduate of University of the Philippine General Hospital for both his medical degree as well as his ophthalmology residency, where he served as chief resident. He then finished his glaucoma training at PGH Department of Ophthalmology and Visual Sciences and at Westmead Hospital, University of Sydney in Australia. Dr. Cobar is currently a consultant staff of UPPGH, St. Luke's Rizal Medical Center, and our very own, the Medical City.
The goal of this case discussion is to share ideas and determine different perspectives in management from the audience and even from our fellow specialists on board today. Isn't it exciting, Itok?
Yes, definitely, Nilo. So again, should you have questions or clarifications for our next speaker, please do not hesitate to type them in the comments section. Let us listen to our speakers. Well, Marimel, the floor is yours now.
Okay. Good afternoon, and it's indeed an honor and pleasure to be here with you tonight. Sorry, this afternoon, we're still in the afternoon. I'd like to thank the Eye and Vision Institute of the Medical City and Mundi Pharma for this opportunity. For this afternoon, I'll be talking about optimizing medical treatment, overcoming barriers. We've learned from the start that the management of glaucoma follows a stepwise approach, and it starts with medical treatment as its first line, and later moving on to laser or surgical treatment if the pressure remains uncontrolled. Laser treatment is the second step, and in the laser in glaucoma and ocular hypertension or light study, selective laser trabeculoplasty was compared to medications in treatment-naive patients in a controlled setting. And the results show that 74% remain drop-free at 36 months, showing significantly better outcomes in favor of the SLT compared to previous studies done. Now, recently, however, the results from a retrospective analysis of more than 800 eyes that underwent selective laser trabeculoplasty from 5 major centers in the United Kingdom were analyzed, and the data released by the UK Real World Outcomes Consortium on SLT. And for the results, the success rate was observed to diminish from 70% at 6 months to as low as 27% by 24 months, with most requiring an increase in the number of drops or additional glaucoma procedure over time. So even after laser treatment, studies have shown that 1/5 to 1/3 of patients require at least one additional medication in the 12 months following the procedure. Now, for the surgical management of glaucoma, significant changes have come about in the last 2 decades with the advent of the minimally invasive glaucoma surgery, or MIGS. MIGS has become an option prior to doing trabeculectomy, and although it has a superior safety profile, having a lower risk of hypotony and bleb-related problems for most of its blebless devices compared to a trabeculectomy, it is, however, less effective in pressure reduction and reducing the medication burden. For more definitive procedures like your trabeculectomy and your glaucoma drainage devices or tubes, in the tube versus trabeculectomy study, the number of anti-glaucoma medications needed after the procedure in the first and third year of follow-up were 2 medications for the tube group. And for the trabeculectomy group, 1 glaucoma medication was needed in the first and third year of follow-up. So this shows us that as the glaucoma progresses from the early to the advanced stage, even after laser or surgical treatment, the medical management of glaucoma continues to play an important role. And we've come a long way since the first anti-glaucoma medication, pilocarpine, was discovered in 1875. And we now have more classes and more options per class. Currently, in the Philippines, we have 5 different classes of topical glaucoma medications. And recently, new glaucoma medications were introduced, although not available locally yet. In 2017, the nitric acid donating prostaglandin, latanoprostene bunod, was FDA approved in the United States. It is a modified prostaglandin molecule consisting of latanoprost and nitric oxide. And because of this, it has a dual mechanism of action, increasing uvuscleral as well as trabecular meshwork outflow. Its mean pressure reduction is 7 to 9 millimeters mercury, and side effects and dosing are similar to latanoprost. Now, in 2018, a new class of glaucoma medication was FDA approved, and these are your Rho kinase or ROCK inhibitors, exemplified by netasertib. It acts directly on trabecular meshwork cells, increasing outflow through the same route, and mean pressure reduction is 4 millimeters mercury. A notable and common side effect, however, with ROCK inhibitors is hyperemia. Hyperemia was observed in more than 50% of patients on ROCK inhibitors, but it tended to be mild and intermittent in nature. There is also a fixed combination preparation with latanoprost called Rocklatan. So these are the new glaucoma medications to watch out for in the future. Now, looking at the efficacy of the commonly used glaucoma medications, we know that prostaglandins have the highest efficacy, and the maximum percentage pressure reduction from baseline at peak was achieved with rimatoprost, and at trough was achieved with travoprost. Now, the concept of diurnal pressure variation has long been well established, and there is also strong evidence for intraocular pressure elevation at night, which is associated with a higher risk of glaucoma progression. This is because at night, when the intraocular pressure increases and the blood pressure decreases, this results in a difference in pressure gradient, leading to a decrease in ocular perfusion. This decrease in ocular perfusion, coupled with less efficacy of glaucoma medications at night, increase the risk of glaucoma progression during the nocturnal period. And this is also why treatment should be aimed at effectively and safely reducing both diurnal and nocturnal pressure. Now, looking at the different classes of medications, prostaglandins show good nocturnal efficacy, while your carbonic anhydrase inhibitors show superior nocturnal efficacy when compared to timolol. Prostaglandins, when used as a single agent, compared to other single agents, have the greatest 24-hour pressure reduction. And aside from prostaglandins, carbonic anhydrase were shown to significantly reduce aqueous production both during the day and night. And in a meta-analysis done by Stewart, it may be the only class to have better nighttime than daytime efficacy. Brimonidine and timolol, however, have consistently revealed reduced effectiveness during the night. We have to keep in mind that glaucoma is a 24-hour disease, so our preferred treatment regimen should cover the patient both during the day and during the night. Now, once we've decided on our first-line single agent, aside from efficacy and safety, optimizing medical treatment will depend on several factors. It's not just a matter of prescribing your medication and expecting your patient to carry out your instructions perfectly to the last detail. We have to remember the nature of glaucoma, being a chronic asymptomatic disease with no immediate improvement with treatment. And side effects, no matter how minor, in this otherwise asymptomatic disease, may make the patients perceive that they are getting worse. Then there is that extra hurdle, which is the challenge of instilling eye drops. So glaucoma may be effectively treated with medications, but they only work in patients who take them. So in order to optimize medical treatment, we have to secure medical adherence. And there are 3 steps: identifying non-adherence, measuring it, and improving adherence. In identifying non-adherence, there are several barriers that we have to consider. For the first barrier, the physician barrier, trust and communication can be issues. Patient barriers include the patient's belief, attitude, understanding of the disease, and health problems like forgetfulness, poor vision, dexterity, and coordination, since most of our patients belong to the elderly population. Now, in a study done by Newman and Cassie on the common barriers to adherence, forgetfulness was the most common barrier observed. Now, in this current pandemic, fear becomes an additional major barrier for both the physician and the patient. Medication barriers include the number, dosing, side effects, and cost of medications. And among the medication-related barriers to adherence, difficulty with medication scheduled ranked the highest, followed by difficulty with drop administration and side effects in second place, and cost in third place. Now, aside from these factors, availability due to the lower supply of glaucoma medications during these lockdown periods, and procurement due to the unavailability of updated medical prescriptions and the difficulty in trying to obtain these medications have become added factors under the medication barrier. Now, situational and environmental factors are fourth, and this includes socioeconomics, patient support, and logistics. Now, once we suspect a barrier to adherence, we should try to measure it. However, in the study by Allhoff, the non-adherence rate was observed to be very variable. It was recorded to be as low as 5 to as high as 80%. And there are different methods in measuring non-adherence. We can do the direct method and observe patients directly as they instill their drops daily, or through detection of the drug metabolites through urine or blood samples, which can be more accurate, but tend to be impractical and expensive. Indirect methods, on the other hand, can range from simple patient interviews and conduction of self-questionnaires to more complex options like electronic adherence monitoring. Studies, however, so far have shown that there is an over-reporting of adherence in questionnaires and interviews. And still, there exists no quantitative standard for measuring adherence. So a question to ask at this point is, why not just use intraocular pressure as an indirect measure of adherence? And the problem with this is the phenomenon called white coat adherence. It has been shown that patients are best at dosing for 5 days before and just after a visit. So using intraocular pressure may not necessarily reflect the patient's true adherence. So once we suspect a barrier because of the difficulty in measuring non-adherence, we can already try to improve adherence, which is the third step. And for the first two barriers, the physician and patient barrier, a patient-centered approach is crucial. Strengthening the physician-patient relationship can be achieved by improving the patient's trust, patient education, actively involving the patient in his care, and open communication, which we should try to incorporate all of these features in each visit, building the relationship with the patient slowly over time. Now, open communication has become a major key point in this current health crisis. We have to keep communication lines open with easy accessibility. Having a dedicated staff and contact hotline will be crucial to address patient concerns, to review missed consults during the lockdown period and schedule future tele or face-to-face consults, to be able to issue updated medical prescriptions by either providing Viber photo messages or a scanned copy of these prescriptions, or to simply provide reminders on the next follow-up visit, or to educate the patient on importance of adhering to their medication schedule. Strengthening the physician-patient relationship, however, is better said than done, because one of the most important limitations then and now will still be time. We probably allot 15 to 20 minutes at most per patient, so getting all these important features incorporated in each visit may not be realistic. So support from the patient's family, office staff, and glaucoma support groups may be very helpful here. Now, for the medication barrier, side effects are a common concern, and this is usually due to the preservatives found in most medications like benzalkonium chloride or your BAK. BAK has multiple toxic effects on the tear film, the cornea, and the conjunctiva. And nearly 60% of glaucoma patients report symptoms of ocular surface disease in at least one eye. Studies have shown that patients on preservative-free medications had a lower rate of self-reported non-adherence compared to patients on preserved medications. So, shifting to preservative-free should be strongly considered in patients on multiple medications and those with ocular surface disease. Now, difficulty with medication schedule is another common problem under the medication barrier, and simplifying dosing regimens through fixed combinations can help. This is because fixed combinations are more cost-effective, there is less preservative overload leading to a lower risk for ocular surface disease, and its simplified dosing regimen leads to less washed out and better adherence and persistence. In the Philippines, we have quite a number of fixed combinations available, with all having a beta blocker component, except the brinzolamide brimonidine fixed combination. And when we have to choose a medication for patients with advanced glaucoma or those with very high pressures, the guiding concept of maximum tolerated medical treatment comes to mind. This was coined in the 1960s and served as a guide till the latter part of the previous century. And it was defined as the achievement of the greatest pressure reduction with the most number of medications that the patient can tolerate and is willing to be compliant with. Unfortunately, however, more medications does not necessarily equate to maximum pressure reduction. And this is because the return of investment for each additional medication added begins to decline after the second-line treatment and so on down the line. And the percentage of reduction may not be additive, especially if both agents have similar mechanisms of action. So how much can we really add, and when is enough enough? Recently, a study on the additive effect of brinzolamide brimonidine fixed combination versus a vehicle to patients already on the timolol travoprost fixed combination was evaluated. So this was a phase 4 double mass 2-arm randomized study, and it was conducted in 134 patients where the primary endpoint was the mean change from baseline in diurnal pressure. The major limitation, however, of the study was the short duration of 6 weeks. And for the results, there was a significantly greater pressure reduction of an additional 4 millimeters mercury when brinzolamide brimonidine fixed combination was used as an adjunctive treatment to patients on the timolol travoprost fixed combination. Ocular adverse events, however, were slightly higher for the arm with the 2-foot fixed combinations compared to the arm with the vehicle and 1 fixed combination. So when we talk about maximum medical treatment now, we are faced with several different combinations. The first 3 having 1 fixed combination highlighted in red plus 2 single agents, and the last combination having 2 fixed combinations. And there really is no wrong combination here. It's really what works best for you and your patient based on efficacy, safety, and medical adherence. However, if you look at the number of drops per day, you can see how certain combinations can significantly reduce this. The old guiding concept of maximum tolerated medical treatment has now shifted to optimal medical treatment, where we strive for fewer bottles but still maintaining effective pressure reduction in order to reach less side effects, a simplified dosing schedule, and better adherence and persistence. Now, looking at that last combination one more time, here we are down to 2 bottles, but covering 4 different classes of glaucoma medications and significantly reducing the number to 3 to 4 drops per day. So this is just one example of effectively shifting maximum tolerated medical treatment to optimal medical treatment. Now, aside from simplifying the medical regimen, for first-time users of glaucoma medications, using illustrations to demonstrate proper eye drop installation may be very helpful. And actually, what I find very effective is writing the time schedule of each drop down, especially if patients are on multiple medications. This is because it not only carries a stronger sense of duty to comply with the prescribed medication schedule, but it also decreases the risk of washout and provides better and uniform spacing of the eye drops over the patient's waking hours. Now, since forgetfulness is one of the most common barriers to adherence, we can fit the medication into the daily routine of the patient by associating it with activities they never miss. For example, we can link the application of prostaglandins to brushing their teeth at night. Now, in this age of technology, reminders from our mobile phones and gadgets can be widely used for this purpose. Now, what about the future directions in improving adherence? Trials have centered on better drug delivery systems. And for our sustained-release drug delivery, several ocular implants are on trial. The Mimatoprost sustained-release implant is injected intracamerally and has a mean pressure reduction of 7 to 9 millimeters mercury over a 6-month period. It is biodegradable, and here are the gonio photographs at 2 weeks, 9 months, and 12 months as the implant slowly decreases in size. Punctal plugs can be loaded with prostaglandins, and both latanoprost and travoprost have been evaluated. And studies have shown a mean pressure reduction of 20% or a pressure reduction of 4 millimeters or more over a 3-month period. Now, examples of your ocular surface implants include your bimatoprost medicated silicone ring, which has a mean pressure reduction of 20% over a 6-month period. And another example is your latanoprost eluting contact lens that shows very promising results in animal studies, and current trials on humans are on the way. Now, for nanotechnology, this is a relatively new field in medicine. It is an emerging science that uses very tiny spherical structures measuring from 1 to 100 nanometers in size, called nanoparticles, which can be delivered in several formulations or different nano platforms. Now, nanotechnology has the potential of addressing limitations in the management of glaucoma, including medical adherence. This is because nanotechnology can provide drug access directly to the target cells by bypassing biological barriers. It has a higher drug loading capacity. It can promote controlled release, and it has better biocompatibility. So these are just some of the examples and the different target sites in the eye where nanotechnology can be applied to address limitations in the management of glaucoma. So to summarize, first, optimal medical treatment can be achieved by careful selection of our medical regimen. Efficacy and mean 24-hour pressure reduction are crucial, so our preferred treatment covers the patient both during the day and during the night. Second, improving adherence should target existing barriers. Strengthening the physician-patient relationship can be achieved by trust, communication, and continuing patient education. For the medical regimen, consider preservative-free in patients with ocular surface disease and those on multiple medications. Remember that fixed combination treatment simplifies the dosing schedule, and optimal medical treatment replaces the old guiding concept of maximum tolerated medical treatment. Finally, future directions will center on improved drug delivery systems, either through sustained release drug delivery or nanotechnology, which hopes to shift the responsibility of medical adherence from the patient's hands to our hands. Thank you.
Hello. Hi, TMC. Hi, Nilo. Hi, Itok. And hi to the Alpha Boys. Thank you for having me in this sixth episode of the EyeTV. These are my disclosures. And this is my disclaimer. So to complement Marimel's talk, I'll be talking about 4 cases with a short discussion after each. The first case is a 41-year-old male. The patient's a general surgeon, complains of blurring of vision, and the patient was a known myope who underwent LASIK surgery 2 years ago. Visual acuity improved after the procedure, but 5 months prior to consult, just about the start of the ECQ, patient started having headaches and eye pain, similar to what he's had prior to his LASIK. With extreme headache, he was prompted consult at the ER, and he was told that his IOP was around 52 and 49. He underwent laser iridotomy, which apparently improved his condition. He was maintained on 4 topical anti-glaucoma meds, and he was asked to have a visual field and OCT done. But due to the ECQ, these were deferred. About a month ago, these tests were done, and patient was told that he had severe glaucoma in both eyes. IOP at that time were 17 and 18, and patient was advised trabeculectomy in both eyes. These then prompted his consult for another opinion. So when I saw this patient, his pupils were 3 to 4 millimeters slowly reactive to light, cornea and lens were clear. There were a few iris pigments on the endothelium. Peripherally, there's 1/4 to 1/2 X, and centrally around 4X deep. There were no iris atrophy. There was a patent LI at the 12 o'clock area. Cup disc ratio around the time was around 0.9 in both eyes, and IOP were 18. On gonioscopy, there was PAS accumulated around 5 clock hours on the right and around 4 clock hours on the left. These were the tests that were done 3 months prior, and then which showed cupping in both eyes. And on perimetry test, which showed generalized depression on the both eyes with a central tunnel of vision. So, and an OCT done which showed generalized RNFL thinning in both eyes. So, if you are to encounter a patient like so, what would you do next? Do you do diurnal IOP monitoring? Do you have the tests done?
Do you do a repeat iridotomy 180 degrees away? Do you start oral medications, or you do none of the above? So for this patient, I asked him to have his visual field done. And not just a 30-2, but I asked for a 10-2 to be done, just so that we can visualize what he's actually seeing at the 10-degree area. So in this perimetry result of his 10-2, you see that there is constriction of field. And on his right eye, you see just around less than 5 degrees of field available. And on his left eye, maybe a little bit more than 5 degrees of field. Other than that, I asked him to undergo an oculus test with a Corvis so that we can get a more precise knowledge of how his IOP measurement is. So luckily, we have this at the medical city. And with this machine, we were able to gauge what his IOP is, considering that he's had prior LASIK surgery. So on his right eye, we see that his IOP is around 15.4. And on his left eye, we see that it's around 16.1. So in this patient, we see a 41-year-old male with an acute angle closure in a myopic patient. That is very uncommon, considering most acute angle closure occur in hyperopic eyes. Normally, the mechanism for pupillary block is a relative pupillary block for myopic patients because of the iridolenticular touch. However, maybe because he's had a laser iridotomy, that was not seen. Also, because of the presence of the PAS, that might not have been the plausible explanation. Bilateral attack of angle closure usually may be caused by various drugs. These may be topimerate, SSRI, your decongestants, antihistamines, and even reported cases from intake of sildenafil. For patients who have undergone PRK and LASIK, it causes a reduction of the postoperative IOP, may be a clinical underestimation of the actual postoperative pressure. So the deeper the ablation, the higher the preoperative IOP, the greater the postoperative reduction of the IOP will be. The myopic refractive surgery causes larger underestimation of the IOP compared to hypermetropic corrections, which are thought to cause negligible IOP change. Luckily for us, we were able to get a better estimation of his IOP because of the Corvis ST. Despite his constricted fields, this patient still drives and surgically operates on his patients. We do want his IOP to be lower, but there's the issue of wipeout, which we all do not want to happen. We are continually monitoring his condition, and I have discussed the possibility of having to do an iridoplasty or a trabeculectomy, but we are leaning towards doing a phaco-GSL to open up the angles and prevent the angle from zipping up. The patient actually doesn't mind applying the drops since he only has 2 bottles with 4 drops in it. He'll be happy with a 2 to 3 millimeter mercury reduction in IOP. Case 2 is a 33-year-old female, a local celebrity, complains of occasional headache. On the day of consult, patient had no complaints. She came in for spectacle correction and routine checkup. She's also complained of prior history of migraine. Her grandmother had glaucoma, and hence she's a little bit worried about her condition. So her VA on both eyes was 20/20. IOP was 18 and 16. Gonioscopy, their angles were open. But on evaluation of her disc, you see that there is some cupping in both eyes. So this prompted me to look at her discs, which appears on your screen at the moment. The topmost 2 pictures are the discs on her right eye, and the bottom pictures are pictures of her left eye. Fortunately, we also had the visual field done on the same day. And after the test showed that on both eyes, she had constricted fields. We also had an OCT done, which showed adequate RNFL thickening, and CCT, which showed more or less slightly uh, corneal thickness, which was a little on the thin side. So what do you do now? Do you start her in the meds? Do you repeat the visual field? Do you suggest a neuroconsult? Or you do just diagnose her as having physiologic cupping and follow up annually? So I actually started her on PGA. Unfortunately, after a week, she stopped using it because it caused her some eye redness. So I shifted her to a CAI timolol fixed combination drop, which she used. After around 2 months of using the drops, I had the test redone. And the perimetry result showed on the right eye, there was a little less constriction of her fields, but we do have some split fixation on the right eye. Left eye was also a little bit better than the first. So with that, I figured, what do we do next? I can't give her any other drops which might cause hyperemia. Or do I just do SLT? Do I repeat the test? Or do I just continue with the treatment? I actually did an SLT on her with continuation of the CAI timolol fixed combination drop. And her latest visual field with me showed that there was still some constriction of her fields, but there was a better central 10-degree area on the right eye. Left eye was also a little bit better. But what worried me more is that during the time that I've been following her up, I probably have had 3 OCTs done on her. All her OCTs showed adequate RNFL thickness. And that isn't compatible with the glaucoma I was thinking about. But if you look closer, you will see that the disc area was 3.16 on the left, on the right, and 2.78 on the left. These values are much higher than what we normally see on a normal patient. So I look for literature, and it says that in the table of values, if the disc area is less than 1.3 millimeters squared or greater than 2.5 millimeters squared, the normative data is not applicable because the database has insufficient number of subjects with the disc areas of these sizes. Hence, I went on with my diagnosis of normal tension glaucoma with her and proceeded with the treatment and management. So, normal tension glaucoma, also known as low tension glaucoma, we see that patients have optic nerve damage when the eye pressure is not very high. Usually, this condition is bilateral and progressive, and NTG patients usually have higher prevalence of vascular disorders such as vasospastic conditions, ischemic vascular disease, coagulopathies, even though the etiology is still so much unclear. In these patients, visual field defects typically appear deeper, steeper, and closer to fixation in patients with NTG than patients with POAG. The amount of visual field loss in NTG tends to be greater than one would expect on the basis of optic nerve appearance alone. It is important to identify and treat any underlying medical conditions associated with NTG, such as anemias, arrhythmias, hypothyroidism, autoimmune diseases, and migraine headaches, which may be related to vasospasm. Vasospasm was first introduced by Flammer to be related to glaucoma. There are 2 recent papers which show that patients with NTG have elevated systemic plasma levels of endothelin-1 and a normal postural endothelin-1 response. These findings suggest that vascular abnormality in NTG is not just confined to the ocular circulation and may indicate that the eye is just one manifestation of more generalized vascular disorder characterized by endothelial cell dysfunction. But there are a lot of other questions other than vasospasm as a cause of NTG, like how does vasospasm relate to optic nerve damage? Or if it's due to some focal ischemia in the ciliary circulation? So these questions need to be answered, and hopefully with more time, we'll be able to know the answers to these questions. So we go back to this patient and we see that if we evaluate the risks and factors associated with her condition, we see that because her condition had bilateral visual field disability, the visual field loss was threatening fixation, and because of her young age of diagnosis, there was a reason for us to treat her condition early. If we look at the collaborative normal tension glaucoma study, we see that with a target of around 30% IOP reduction, there is a 26.5% progression rate among the untreated group, and the patients who were treated, there were 12% only of progression rate. So hence justifies our treatment for this patient. Case 3 is a 47-year-old female who consulted for routine checkup. 4 years prior to consult, patient came in from the US to take care of her sick mother with glaucoma and who just recently had a cerebrovascular attack. She's been wearing glasses ever since she can remember. So on routine checkup, she actually also just wanted spectacle correction. On physical exam of the patient, she had 3 millimeter pupils, which were equally reactive to light. Cornea and lens were clear. The angles were open, and the AC was formed and deep. Her visual acuity was correctable to 20/20. She was a myope with a minus 425 and minus 375 correction. When I looked at her disc, she had some degree of cupping of around 0.8 in both eyes, and IOP was around 20 in 18. So I had perimetry tests done, and her test showed that on her right eye, she had an incomplete inferior arcuate scotoma or a large nasal step. Left eye was okay at the time. An OCT was also done, which showed and coincided with the defect she had on her right eye, for there was a superior RNFL defect and generalized thinning at the macular area on her right eye. So I started this patient on PGA timolol fixed combination on her right eye, and subsequent follow-up showed that IOP of around 16 in both eyes over a span of around 6 months. 6 months later, a repeat visual field was done, which showed a little bit progression on the right eye, wherein the inferior arcuate was slowly trying to complete. So I added Simbrinza on her right eye and added some lubricants as well. Subsequent follow-ups had her IOPs down to around 12 to 14, and on the left, it was up to 16. 4 months later, I had a repeat of her visual fields, but unfortunately, she had an octopus test done. It's hard to compare Zeiss test from an octopus, but on this octopus test, we see that there's a completion of her inferior arcuate scotoma. This prompted me to increase her dose of Simbrinza to 3 times a day and continued the PGA timolol fixed combination. So on her last follow-up this June, her visual field done back with a Zeiss test showed that she had an incomplete inferior arcuate scotoma, and her pressures were maintained at 12 to 14, and her left eye was stable at 16. She was happy that to be maintained on 2 bottles of anti-glaucoma meds plus lubricants to help ease symptoms of dry eye. This was her last OCT with me as well. It showed persistence of the thinning, the RNFL thinning on the right eye, but we also see that there was some thinning at the macular area of her left eye. So with that, we actually started some anti-glaucoma on her left eye as well, even if visual field changes have not been seen on that eye. So we all know that glaucoma has risk factors. So the most common is advancing age, myopia for open-angle glaucoma, hyperopia for angle closure glaucoma. We have medications, previous ocular trauma or surgery. We have diseases such as uveitis, family history, systemic disorders, and intraocular pressure. And for this patient, her risk factors are myopia and family history. So most of the studies have suggested that there is a direct correlation of myopia to open-angle glaucoma. There are a lot of epidemiologic studies which will confirm this, but the most notable to me and the most familiar with me is the Blue Mountains Eye Study, because this was performed in the hospital I was affiliated with. In their study, it showed that there is an odds ratio of around 2.3 times probability of having glaucoma in low myopia and a 3.3 times more in patients with moderate to high myopia. High myopia in itself often makes detecting glaucoma difficult because optic nerve features may confound glaucoma to changes. In addition to that, pathologic myopia may cause visual field defects and retinal nerve fiber layer thinning that are indistinguishable from those found in glaucoma patients. So it has been postulated that the optic nerve head in myopic eyes may be structurally more susceptible to glaucomatous damage because of the changes in connective tissue structure. The last case is that of a 23-year-old female who came for blurring of vision on her left eye. 9 years ago, the patient came in for a second opinion. She was already seen in the province, was given anti-glaucoma meds, but because of persistent blurring of vision and occasional headache, patient sought consult. There was also no history of trauma. At the time, the patient had 3-millimeter pupils, the right eye was quickly reactive to light, the left eye was slowly reactive to light. Cornea and lens were clear, there was no iris atrophy, no rubiosis, and visual acuity was correctable to 20/20 on the right and 20/25 on the left. At the time, there was very much large cupping on the left with 0.95 and on the right of 0.8. IOP was also elevated on the left with 42 millimeters mercury. So this was a sample of one of her numerous visual fields I had done on her earlier on. You will see that on the right, you have a clear visual field, and on the left, we have a generalized depression on 30-2, 24-2, sorry, but on the right, on the 10-2, we see constricted fields with less than maybe 3 degrees of field remaining. So the patient was diagnosed with JOAG on the left, and patient was subsequently underwent trabeculectomy on her left eye. Patient was followed up for years, and the left eye was off medications, and the right eye was continually being monitored. Eventually, after 2 years of the surgery, she had to start on Travatan, on a once-a-day dosing. I show this slide because I want to emphasize that sometimes when we order visual field, we have to write down that we want a 10-2 done. Otherwise, technicians might not perform a 10-2 even if there's a severe generalized depression on the perimetry test. So, over the next 7 years, the patient has undergone cataract surgery and Marvel tube implantation on her left eye. So I saw the patient when she was a grade 6 student, and just last year she graduated from college already. And from these charts, we're able to see that from 2013 up to 2020, we were able to preserve the constricted fields that she's had ever since she consulted. So although she's had around 3 to 4 degrees field left on her left eye, she's had it and just still able to see 20/20 until this time. Currently, this patient is on PGA on both eyes. She started Simbrinza on her left eye, which is her worst eye. Her IOP on the right is 12/14, on her left is 13/16, and she's correctable to 20/20 still. We've had to start medication on her right eye because of the thinning at the superior area of the RNFL on her right eye. So For this patient with advanced JOAG and high risk for visual loss, we have a patient with advanced disease at the time of presentation. We have a patient with visual field loss affecting fixation and a young age at diagnosis. Hence, we have to treat her aggressively. Based on the AG study, they said that statistically, if your IOP was greater than 18, sorry, it's less than 18 at all times, there will be no visual field change. However, the sample patients that they had for that study was only for mild to moderate glaucoma. So a predictive analysis was done, and if it included severe glaucoma, they came up with an IOP of less than 14 to have no visual change in these types of patients. The treatment outcomes in the tube versus trabeculectomy study after 5 years of follow-up showed that the IOP was 14.4 in the tube group and around 12.6 in the trabeculectomy group. Although the trabeculectomy group had a lower IOP during that time, the failure rate at 5 years was lower in the tube group at around 30%, whereas the failure rate for the trap group was around 47%. Also, the rate of reoperation for glaucoma was only 9% in the tube group compared to around 30% in the trap group. So the tube shunt surgery had a higher success rate compared to trabeculectomy with mitomycin during the 5 years of follow-up. Having said that, the tube group was also noted to have more comorbidities after the surgeries. So the goal of treatment of glaucoma is to maintain the patient's visual function and related quality of life at a sustainable cost. The cost of treatment in terms of inconvenience and side effects, as well as financial implications, should have also a careful evaluation. Based on the Asia-Pacific Glaucoma Guidelines in 2016, wherein representatives from Asia and Australia gathered to have a consensus agreement, we set forth guidelines wherein we look at the balance of disease stage, progression rate, and life expectancy of the patient. Based on this, we categorize this patient based on risk assessment for patients with glaucoma with a high 5-year risk of progressive visual loss. These patients are the ones with high IOPs, bilateral visual field loss, young patients, secondary glaucoma, and angle closure, or those with advanced visual field loss and fixation threat. Or the next group, the glaucoma with moderate 5-year risk for visual loss. These are patients with mild glaucomatous optic nerve defect with visual field loss, patients with mild to moderate glaucoma with low IOPs. And then the third group, the glaucoma suspect at moderate risk for visual loss. These three groups will now tell us on how much target pressure reduction we may want to target. For those with high risk for progressive visual field loss, you may want to target a reduction of greater than 40% or 1 to 2 standard deviations below the population mean, which is around 9 to 12 millimeters mercury. For those with moderate risk, you may want to target 30% reduction. For the glaucoma suspect at moderate risk, you may want to target a 20% reduction. And for those with low risk, you may want to follow them up. This is an important graph which tells us the visual field loss over time. This line represents the line of decrease in visual field as a patient ages. This line looks at how the visual field progresses over time at a much faster risk than that of aging. If a patient starts treatment early, we may be able to decrease the slope of the progression, hence follow the line or slope of that of normal aging. However, if there is a stop or discontinuation of the treatment of a patient, then his condition might still progress at that steep slope. So it is very important that patients are treated, whether medically or surgically, so that the slope does not follow that of the steep slope of progressing, wherein the visual field defect might get worse. This is the algorithm of what we have for the Asia-Pacific Glaucoma Guidelines, wherein we start off with the first choice of monotherapy, depending on how severe the condition is. And then if the patient's condition and the IOP is achieved, we monitor the patient. If the patient's condition is not achieved, then we add another medication or we switch until we are happy with the monitoring of the patient's condition and there's no progression in the visual field. In summary, the treatment of each glaucoma patient should be individualized. We should be familiar with all possible treatment options like the medications, lasers, and surgery. We should know the indications, contraindications, and the adverse effects of these medications. We should explain well to the patients the better understanding and compliance, and we should treat the patient rather than just the IOP. So hopefully we will be able to beat invisible glaucoma and invisible COVID as well. Thank you very much and stay safe.
Well, thank you, Marimel and Rainier. Those were really great lectures, no? As glaucoma specialists, learned a lot from your lectures. And I'm sure all our viewers also learned from what you have discussed. So now let us call back Dr. Veloso, Dr. Cobar, as we begin the second part of this afternoon or this evening's Q&A.
Okay. Can we have the questions? Okay, the first question may be for Dr. Veloso. How will the results of the light study, the SLT light study, change the management of glaucoma?
Okay, actually, this is a very good question because you want to know what to do with the results of the light study and how you're going to apply it in your clinical practice. Now, let's just go back to the key points in the light study. Remember that in this study, they compared SLT with medications, and SLT had a very favorable response with more than about 74% being drop-free until 3 years after the procedure. And if you compare it to previous studies done, as I mentioned, it's also more favorable results for the light study. Now before we interpret the results of the light study and apply it to our clinical practice, we have to look at the patient profile of the light study. I'm just going to mention 3 key points here. Okay, the light study, these were treatment-naive patients. So these were patients without any previous medical, laser, or surgical treatments. These were also patients in the early stage of glaucoma or ocular hypertensives. More than 80% of them were in this profile. And third, 70% were European Caucasians with only a 6 to 7% representative from the Asian population. So will I offer it as a first line for patients with a similar profile like open angles that are in the early to moderate stage and open and ocular hypertensives? Why not, since it's a relatively safe procedure? But I would discuss with the patient the study and also the patient profile that was characteristic of this study. But will I change my algorithm just yet and already do it for all ocular hypertensives and early open angles? Probably not. I'll probably wait for RCTs in Asian populations first.
Thank you, Marimel, for clearing that out. Maybe the second question can be answered by Rainier. This time, Rainier, the question is, would you recommend routine dry eye evaluation before starting anti-glaucoma medications as a way of reducing adverse reaction and improving adherence?
Thank you very much for your question, Itok. Ideally, we should actually be looking at all aspects of the patient, including the dry eye. But unfortunately, sometimes when we have a very busy clinic, we sometimes tend to just focus on what is important to us, such as the glaucoma. We all know that glaucoma is a severe condition, and sometimes that is what we want to concentrate on. However, having said that, um, I actually do start most of my patients on lubricant once I give them medications which may cause dry eye, such as maybe a beta blocker or alpha-adrenergic, or maybe when I use drops like a PGA, which I know might be irritating to them. But like I said, ideally, if we can do a dry eye test, then that'd be good. But if not, we can supplement the drops that they have with lubricants as well.
Yes.
Thank you, Rainier. Do you have more questions? Oh, here is another question. Given the rising popularity of teleconsultation in ophthalmology, any advice on how to optimize medical management of glaucoma virtually? Maybe I think they're asking about the measurement of the pressure.
Yes. Um, so for optimizing medical treatment, no, and then of course for patients with glaucoma, you need to get the pressure. You cannot just the teleconsultation. Let me just emphasize that it's still important because you get to know how the patient is. You can ask them about their vision, how they are. If there's any changes, you can also ask them about if they need prescriptions that are updated or they are having difficulty obtaining medications. But for me, you have to like tie up with someone that's close to your patients, proximity wise, because like what I do usually for patients that cannot come in for face-to-face consults is they still have to get their pressure. So I look for somebody close to them that I know where they can have their pressure checked, and then I do teleconsultation with them once they have that. Is also true for also the tests, visual field and OCTs that you have to do. You can find someone near your patient's place, like especially those in the province, as I mentioned, that can do it for you and send it to you, and then you can talk to the patient after you've received these results.
Actually, teleconsultation is very difficult for glaucoma, as you all know, because we won't have the luxury of measuring eye pressures as well as looking at the nerve and having any diagnostic test available with us. I think that, in fact, that's one of the projects that I think PGS has, because we are circulating the clinics of all the practitioners around us so that a patient may go to one of the clinics of anyone who may check the IOP of these patients, so that more or less we may have an idea if their IOPs are controlled. Otherwise, looking face to face like this, it's very difficult for us to say if your condition is getting worse or not.
Any one of you venturing in the using of the triggerfish, the contact lens measuring device for IOP?
The problem with the triggerfish, Milo, how expensive is it? I'm not so
Yeah.
familiar, yeah. And I know that there's also some issues with the triggerfish, although it's the closest to getting a semi-continuous pressure that mimics the different positions, no, during the day and night. But I know there are problems like after 24 hours that it's not as good in detecting the changes in the corneal curvature. So the pressure detection after 24 hours may not also be that reliable compared to your GAT. But I hope they can come up soon with something that's less expensive and more accurate.
Yeah, because
Actually,
sometimes more patients would ask us about it. No, it's not the doctors that offer it, but rather the patients reading internet articles. Yes, Rainier.
Actually, Milo, eye care has a home care device which you can use to monitor your IOP. So it's a self eye care device, similar to what we use to check the IOP of patients who've undergone PKPs, or patients who are young patients or children. Some patients can buy it and then they upload it to a computer, and then the data or the IOP may be downloaded and transferred to their doctors.
Yeah, but
But
it's quite expensive then. It's quite expensive. The eye
it,
care.
it it's not as expensive, sir, as the eye care, which may cost around 400,000. It's
Oh,
not as expensive as that. Maybe $1,000, I think.
mhm.
Any more
Okay.
questions?
Any more question? Okay. This another question. How do you optimize medical treatment in pregnant patients?
Um, Actually, for pregnant patients, no, so it's a toss-up always between trying to control the glaucoma and protecting the child. No, so usually it's a good thing most of our patients are 40 years and above, but of course we do get patients younger than that. And what I always try to tell my patients that are on chronic treatment with glaucoma medications that are in the childbearing age group is to inform me if they plan to get pregnant. Like if they're in the early to moderate stage, I usually consider doing like an SLT before their pregnancy. Although SLT has been deemed to be relatively effective and safe during all trimesters of pregnancy in the limited studies done. No? But also for advanced cases, kasi if ever like their pressures are borderline and then in the advanced stage, you might already want to consider doing a trabeculectomy before your pregnancy. Now, with regards to the medications, no, in pregnancy, the only class B, meaning the only acceptable, less harmful to the fetus is the brimonidine. Yeah, because
Yeah.
all the other anti-glaucoma medications are class C. So just be careful. I would always tell my patient that I would want to co-manage with their OB. And as I mentioned, you can always offer SLT to lessen the number of eye drops the patients are on during their pregnancy. And then also, with regards to if you are really pushed against the wall and you have to do a trabeculectomy during pregnancy, try to delay it for the second or third trimester. But of course, there are still risks, but less on the fetus because of the antimetabolites, the anesthetics, the sedatives used during pregnancy for the trabeculectomy surgery.
Thank you,
Yeah,
Marimel.
that's
Yeah, I
very,
agree
very
that SLT
difficult.
is okay.
And if a
Okay.
patient has to have drops, maybe punctal occlusion might help, just so that you lessen the systemic absorption of these medications.
That's good.
Yeah, good suggestion.
Okay.
Okay, I think we have another question. For patients whose adherence cannot be assured due to financial reasons, would early glaucoma surgery be an appropriate option? Rainier, can you answer this?
Of course, it depends on the severity of the glaucoma. Um, it's hard to justify operating on a mild glaucomatous patient just because of financial reasons. Because there are cheap, right now there are cheap alternatives for medications, because not all medications are that expensive. So depending on the severity. But of course, there are patients who will really benefit from having a surgery done, especially since if they might not be able to be seen by a doctor because they live in far away places or because of this ECQ. So for as long as we follow the dictum that we do no harm to the patient, then that's fine. But like I said, if as much as possible we can treat mild diseases with cheap the maybe beta blockers, which might not be that expensive, then that's fine. But otherwise, if that will really be expensive for them, then and doing chab is really the only option,
Yes.
then better than not doing anything.
Yes, I will agree to that too. No, pagka they really cannot buy medications because of their financial concerns or reason, trabeculectomy will it will resolve the problem for them because of really cannot buy any anti-glaucoma medication.
Or maybe SLT, sir, because having said that, if you do a trap, then they also need to buy the prednisolone
Anti-post-op.
acetate afterwards. And if we just do a trap and let them go, chances are they'll come back with failed traps afterwards. So we all know that post-operative management of trap is very important as well.
Okay. Any other question? Okay, here's another one. Did the entry of MIGS device change the management algorithm? Earlier surgical interventions for patients who are able to afford it. So I think, Marimel, you have a slide regarding that.
Yeah. Yes, I did. Actually, I just wanted to just say na that when MIGS came in, it became an option prior to doing trabeculectomy. But as we also mentioned in the results of most of the studies on the different devices under MIGS, you would probably do it more for early to moderate stages of glaucoma because the pressure control really isn't as good as a trabeculectomy. So in terms of advanced glaucoma, I would still go from I would bypass the MIGS and go for the trabeculectomy. I think Rainier has done a lot of MIGS also. And Rainier, your thoughts on this?
Ma'am, MIGS is, well, when they conceptualized MIGS, they thought they came up with a wonder procedure that can solve all glaucoma. But as it turns out, MIGS is only really good for mild to moderate glaucoma. And it's very hard for most of the MIGS to accomplish an IOP lower than what trabeculectomies achieve. So, and of course, it has the limitation that you want to use it only on patients with virgin conjunctiva. So if a patient has had other ocular surgeries, they might not be good candidates for it. So it's still part of, I think it's still part of the algorithm, but we usually relegate the MIGS to mild and moderate glaucoma. And as we know, mild moderate glaucoma, these patients are the ones who technically can still be controlled by medications. But if the patients don't like to put in their anti-glaucoma medications and they've had their SLTs and ALTs done with not much improvement, then this is the next option prior to having a trabeculectomy done. So it's still part of the algorithm, but maybe not as deep as a trab.
Yeah. It still has a niche, but the problem is still the cost, the steep cost. Okay, so second to the last question, how can we determine if the improvements in the visual field were due to the treatment done and not just the learning curve of the patient?
I think it's a matter of establishing your baseline visual fields, no? Remember in the beginning, there will be some fluctuations. So that's why you have to get several and use this several fields. You sort of like that it becomes like your baseline. It's not just one field because there can be learning curves really there. If you have several as a baseline to compare with, it will be easier for you to know whether your treatment is working or not. But you have to start first with good baseline visual fields. And it's usually not just one, it's more than one. Probably on your third or fourth, when the patient already gets used to doing the test.
Yeah, I agree, Marimel.
Okay, I think this will be our last question. Can you summarize the important key options, key points on ways we can optimize medical treatment during this COVID pandemic? Marimel?
Okay, so actually I already mentioned this in the lecture. Let me just summarize some points. No, again, aside from all those barriers we mentioned, fear is an additional barrier for both the patient and the physician. So if ever we do face-to-face consults, we should also make the patients feel that it's safe, the surroundings are safe, the least possible transmission of COVID, and with regards to medications, as we mentioned, because a lot of my patients, I don't know if it's the same for all of you, had problems obtaining medications during lockdowns because of the lower supply, and they didn't have updated medical prescriptions. So I would tell them to stock up a bit, maybe 2 to 3 bottles. So if ever it happens again in the next few weeks, at least they have a backup there already with them. And then, as you mentioned, communication with your physician, because it's through you that they can get these updated medical prescriptions, or if they have other concerns, they will be able to ask you if they're having side effects with the medications. You can already advise them on what to do next.
Okay, good points, Marimel. So I think we've answered everything. If there are no additional questions, please see our comments section for the link and a bill of the betadine oral gargle sample from Mundi Pharma. Thank you all for tuning in this afternoon, and know that without you, our viewers, TMC ITV's vision would not have been come into fruition. All right.
Again, again, thank you everyone for your questions and for the extensive discussion. We would like to express our gratitude to our guest speakers, Rainier and Marimel, for allowing TMC ITV to be a platform where they can showcase their knowledge and expertise.
Watch out for our next episode in 2 weeks' time. We explore the potential of digitization in surgical training of our ophthalmology residents through the size Artebo 300D digital microscope.
Now that sounds exciting and fun. We hope the residents, fellows, consultants, and faculty of different training institutions in the country and around Asia will tune in to this episode in partnership with ZEISS as we look to new ways to innovate ophthalmology training in the Philippines.
So watch us live on August 27. That's Thursday again, 5 p.m. via our YouTube channel.
I would like to take this opportunity to thank today's sponsor, Mundi Pharma. You may add our official TMC EVI Facebook account to access details of our episodes and get notified for new live videos through our YouTube channel. Please do click on the subscribe button below, and we'll see you on the next episode. Again, I am Nilo Flor Cruz.
And I am Itok Reyes. Thank you for watching this 6th episode of TMC ITV. Let this be our every other Thursday habit from 5 to 7 p.m.
Thank you for being a part of TMC ITV, and we hope you'll join us as we further explore ophthalmic instruction without borders. Have a good night, everyone.
Bye. Thank you.